Assalamu alaikum and a very warm welcome to all my students on the behalf of Anatomy Department, Akhtar Said Medical and Dental College. I'm Dr. Amna Rafeel, here to present you our today's topic, that is gross anatomy of inguinal region. So the objectives of our today's lecture, that is by the end of the lecture you would understand very well what inguinal region is, where inguinal region is located, important anatomical structures located in this inguinal region, including the inguinal ligament, its attachments and extensions. Inguinal canal, that is a very important topic on examination point of view. Its boundaries, its contents will be discussed with you in detail as well. The purpose of inguinal canal in our body, how it works, the mechanisms, how it maintains its integrity, and applied anatomy, precisely the hernias, will be discussed with you in the next lecture on Saturday. So before moving forward to study the details about the anatomical structures present in the inguinal region, I would like you to show where these inguinal regions are located. So you must be familiar with this diagram if you're taking your introductory class about the planes which were dividing the abdomen into various regions. So over here, the region which we are going to study today is this inguinal region, also known as the iliac regions. So over here, this is the right iliac or right inguinal region, or this is the left iliac or left inguinal region. So moving forward about the introduction, that what inguinal region is, so also known as the groin region. So the groin or the inguinal region is the area of junction between the anterior abdominal wall and the thigh. So over here you see this is the anterior abdominal wall and this is the thigh, and the area present at the junction of this anterior abdominal wall and the thigh, this is known as the inguinal region. So starting with the structures located in this inguinal region is the inguinal ligament, also known as the Popart's ligament. You people must have studied inguinal ligament in your first year lower limb anatomy, and the purpose of studying again this inguinal ligament over here is that its various extensions and modifications are contributing in the formation of boundaries of your next topic, that is inguinal canal. So what is inguinal ligament? It's a lower border of epinerosis of external oblique. So what happens when the lower epinerotic border of the external oblique muscle, it gets folded upon itself and gets attached at anterior superior iliac spine and the pubic tubercle, forming a cord-like structure, and that is known as the inguinal ligament. So it's a lower border of epinerosis of external oblique muscle extending from the anterior superior iliac spine to the pubic tubercle, and from pubic tubercle it is reflected to form lacunar ligament and is continuous with the fascia lata. Here you can see that this is the epiderosis of external oblique muscle, and the epinerosis of the external oblique muscle, the direction of the arrow shows how the fibers they get folded upon themselves and making a cord-like structure that is attached at the anterior superior iliac spine and the pubic tubercle, and this is forming a inguinal ligament. Now a triangular shaped extension from the medial end of this inguinal ligament, it goes downwards, and this triangular shaped downward extension of the inguinal ligament is known as the lacunar ligament, that I will discuss with you in detail in the next slides. So this is a lacunar ligament, a downward triangular shaped extension from the medial end of this inguinal ligament, and the epinerotic fibers of the external oblique muscle, they get folded upon themselves and forming a cord-like structure, and that is known as the inguinal ligament. So coming up with the attachments of the inguinal ligament, that is the fascia lata, the deep fascia of the thigh, you must have studied in your lower limb anatomy. that the deep fascia of the thigh, the fascia lata, is attached to the low border of inguinal ligament, and the traction of this fascia, the pull of this fascia, makes the ligament convex. The upper surface of the ligament gives origin to the internal oblique from its lateral 2/3 and transversus abdominis from its lateral 1/3, and to the cremaster muscle from its middle part. You people must have studied in your previous lecture. So over here in this diagram, you can see easily that this is the internal oblique attached at the lateral 2/3 of the inguinal ligament. This is the inguinal ligament. This is the internal oblique attached on this lateral 2/3, and this is transversus abdominis attached in its lateral 1/3, and this is the cremaster muscle surrounding the spermatic cord in its middle part. So the lowest fibers of this internal oblique and the transversus abdominis muscle will combine together and forming a structure that is known as the conjoint tendon that arches over this inguinal canal and then get inserted on the pubic crest and the pectineal line. Here you can see this is fascia lata attached in the low border of inguinal ligament. So coming up with extensions of the inguinal ligament, and those are the lacunar ligament, also known as the Gimbernard's ligament, and also known as the pectineal part of inguinal ligament. The pectineal or the ligament of Cooper, reflected part of inguinal ligament. So these are the extensions of the inguinal ligament, and the purpose of studying the extensions over here is that these extensions of the inguinal ligament or the modifications of the inguinal ligament will contribute in the formation of various boundaries of the inguinal canal. So coming up with the first extension of the inguinal ligament, that is known as the lacunar ligament, also known as the Gimbernard's ligament or pectineal part of inguinal ligament, is a part of epinerosis of external oblique muscle. So why it's mentioned external oblique? Because inguinal ligament is itself the modified part of epinerosis of external oblique muscle. So basically this lacunar ligament is a triangular shaped downward extension from the medial end of inguinal ligament, and this triangle has an apex and it has a base. The apex is attached to the pubic tubercle and the base is directed laterally, and if you remember when you have studied in the first year lower limb anatomy that this base of the lacunar ligament will be forming the medial boundary of the femoral ring. So a triangular shaped downward extension from the medial end of inguinal ligament is known as a lacunar ligament. This triangle has an apex and a base directing laterally. It has an anterior border, it has a posterior border. The anterior margin is attached to the inguinal ligament and the posterior margin is attached to the pectineal line. So coming up with the next extension of the inguinal ligament, that is the ligament of Cooper, also known as the pectineal ligament. So it is basically this is the inguinal ligament and this is the lacunar ligament. As I told you earlier, this is the triangular shaped downward extension from the medial end of inguinal ligament. And so what is the pectineal ligament or the ligament of Cooper? Basically the fibers from the base of the lacunar ligament, they project backward and they get attached along the pectineal line which is present in the superior ramus of the pubis, and this the fibers projecting from the base of this lacunar ligament along the pectineal line is known as the ligament of Cooper or the pectineal ligament. So this is the lacunar ligament, a triangular shape extension with apex and a base, and fibers from the base they project beyond along the pectineal line present in the superior ramus of the pubic bone, and they are known as the ligament of Cooper or the pectineal ligament. So coming up with the last extension of the inguinal ligament, that is the reflected part of inguinal ligament. It is inconstant and it is a thin triangular band which passes upwards and medially from the medial part of inguinal ligament from the pubic tubercle, and it is reflected from the pubic tubercle towards the linea alba. It also has some reflections from the lacunar ligament. So reflected part that is the last extension of the inguinal ligament. It's inconstant, and it is a thin triangular shaped band. The fibers rises from the medial end of the inguinal ligament, that is from the pubic tubercle, and they goes upward and medially towards the linea alba, where they interlace with the fibers from the opposite side. So here's a very good diagram showing you all the extensions of the inguinal ligament. This is the anterior superior iliac spine, and this is the pubic tubercle. This is the inguinal ligament, and this downward triangular shape extension of the inguinal ligament is known as the lacunar ligament. This is the apex of lacunar ligament, and this is the base of the lacunar ligament. It has an anterior border, it has a posterior border. Anterior border is attached to the inguinal ligament, and posterior border is attached to the pectineal line. The base is directed laterally, and this is the inguinal ligament. This is the inguinal ligament, and this is the lacunar ligament. So fibers from the base of the lacunar ligament, they project beyond to be attached on the pectineal line, and this ligament now is known as the pectineal ligament. Fibers from the medial end of the inguinal ligament, they project upward medially. This triangular shaped band of ligament is known as the reflected part of inguinal ligament. From the medial end of inguinal ligament goes upward medially towards the linea alba. So these are the three modifications, very easily visible in this diagram. So coming up on the conjoint tendon. The conjoint tendon is the combined insertion of transverse abdominis and internal oblique muscle into the pubic crest and pectineal line. So what happens is that the fibers from the transverse abdominis and the internal oblique muscle, they combine together and they form a common structure that is known as the conjoint tendon. And this conjoint tendon, which is inserted on the pubic crest and the pectineal line of the pubic bone. So the purpose of telling you the conjoint tendon over here is that when I discuss the boundaries of the inguinal canal with you, for like if I say the roof is from the conjoint tendon, so you people must know what conjoint tendon is. So it's a combination. It's a combined insertion of transverse abdominis and internal oblique muscle, forming a common structure known as conjoint tendon, also known as the falx inguinalis, and that is attached on the pubic crest and pectineal line of the pubic bone, and it is contributing in the formation of different boundaries of the inguinal canal. So another important point I want to discuss with you over here are the two reference points usually being called upon. Those are the mid-inguinal point and the midpoint of inguinal ligament. So what is the difference between those 2 points is, if I draw an imaginary line between the anterior superior iliac spine and the pubic symphysis, and if I take a point midway between this line, that point will be known as mid-inguinal point. And if I draw a line between anterior superior iliac spine and the pubic tubercle, that is the attachment of the inguinal ligament, and the midpoint of this line will be the midpoint of inguinal ligament. So there are two things different. Midpoint of inguinal ligament is different and the mid-inguinal point is different. In mid-inguinal point, the line is drawn between the anterior superior iliac spine and the pubic symphysis, and a midpoint has been taken. While in midpoint of inguinal ligament, a line has been drawn between the anterior superior iliac spine and the pubic tubercle, and the midpoint is being taken, and that is known as the midpoint of inguinal ligament. These two things are separate. Here you can see very easily demarcation on the basis of color, that the blue one shows the mid-inguinal point and the red one shows the midpoint of inguinal ligament. The blue line shows the reference points are between the anterior superior iliac spine and the pubic symphysis, and the midpoint of this line will be known as mid-inguinal point. And on the red line you see the reference points are anterior superior iliac spine and the pubic tubercle, and the middle of that line will be the midpoint of inguinal ligament. Coming up with our next very important topic, and it is very important on examination point of view as well. Inguinal canal. This is an oblique intermuscular passage in the lower part of the anterior abdominal wall, and it is situated just above the medial half of the inguinal ligament. So inguinal canal is an oblique intermuscular passage which is situated in the lower part of anterior abdominal wall in the inguinal region, just above the medial half of the inguinal ligament. So the location of the inguinal canal is the inferior part of the anterior lateral abdominal wall, just above the medial half of inguinal ligament. So this is the inguinal ligament, this is all your groin, and this is the inguinal ligament, and it is situated, the inguinal canal is situated just in the inferior part of anterior lateral abdominal wall, just above the inguinal ligament. So this is the inguinal canal, and it is situated above the medial half of inguinal ligament. So here you can see the exact location of the inguinal canals in our body. These are the oblique intermuscular passages present just above the medial half of inguinal ligaments till the midpoints of inguinal ligament, and these canals are situated in the inguinal region. And of course, if this is a canal, it is an intermuscular passage, so it must have two openings. The canal must have an entry and an exit points, and the two openings on its two ends. This is the medial end of the inguinal canal, and this is lateral end of inguinal canal. The medial end has a triangular opening. You can see this diagram, and that medial opening is known as the superficial inguinal ring, and the opening present at the lateral end, it is oval in shape, and this is known as the deep inguinal ring. Here in the purple you can see the spermatic cord is traversing through this inguinal canal in case of males. Here you can see in this diagram that this is the anterior superior spine and pubic tubercle, and this is the inguinal ligament, and this inguinal canal is present just above the medial half of inguinal ligament till this midpoint of inguinal ligament. This canal obliquely present, it's not straight, and it has two openings on either side. So this is the medial opening and this is the lateral opening. This medial opening is known as the superficial inguinal ring, and this lateral opening is known as the deep inguinal ring. So the length and direction of the inguinal canal, it is about 4 centimeters, around 1.5 inches long, and it is directed downward, forwards and medially. It's not placed straight, it is in oblique direction with the direction facing downwards, forwards and medially. So the canal, the inguinal canal, is extending from the deep inguinal ring to the superficial inguinal ring, that it has two openings on either side through which the structures must be entering and exiting. The one opening is present on the lateral end, known as the deep inguinal ring, as I have shown you and mentioned that earlier, and the one opening is present on the medial end, triangular in shape, and that is known as the superficial inguinal ring. So if I consider the inguinal canal, a right-sided inguinal canal I've taken as an example, if I consider it is like a box which has four sides. So imagine the right-sided inguinal canal viewed from the front as a box with anterior and posterior walls, a roof and a floor. The arrow indicates that the structures can run through it from the lateral to the medial end. In males it is the spermatic cord, and in females it is the round ligament of uterus. So I have taken this right-sided inguinal canal and I have converted that into a shape of a box. It has four sides. This is a roof of that inguinal canal. This is the anterior wall of the inguinal canal, This is the posterior wall you are seeing behind, and this is the floor underneath. And the direction of the arrows shows that how the structures are passing or transmitted through this canal. So in males it is the spermatic cord, and in the females it is the round ligament of uterus. So before moving forwards to the boundaries of the inguinal canal, let us discuss the openings on both the ends, that is the entry and exits of the inguinal canal. The deep inguinal ring, it is an oval opening in the fascia transversalis, which is situated 1.2 centimeters above the mid-inguinal point and immediately lateral to the stem of inferior epigastric artery. So deep inguinal ring, an opening present on the lateral end of the inguinal canal. It is basically an oval opening. It is a weakened area present in the fascia transversalis, 1.2 centimeters above the mid-inguinal point, and lies immediately lateral to the stem of inferior epigastric artery. So here you can see the inguinal canal, and this is the posterior wall of inguinal canal. This is the floor of the inguinal canal, and I have removed the roof and the interior wall so that you can easily see where the deep inguinal ring is present. So this is the lateral end and this is the medial end. So the deep inguinal ring is an oval opening which is present in the fascia transversalis, and it is present at the lateral end of inguinal canal. So the superficial inguinal ring, as we discussed, that the deep inguinal ring present at the lateral end of inguinal canal is an oval opening in the fascia transversalis. So the superficial inguinal ring is a triangular gap in the external oblique epinerosis, and it's shaped like an obtuse angled triangle. The base of the triangle is formed by the pubic crest. The two sides of the triangle, that is the lateral or the medial margins, it is 2.5 centimeters long and 1.2 centimeters broad at the base. These margins are referred as the cruras, and beyond the apex of the triangle, the two cruras are united by intercrural fibers. So superficial inguinal ring is a triangular shaped gap present in the external oblique epinerosis, and this opening is present in the medial end of inguinal canal. The triangle has a base and an apex, two sides. I'll show you in the diagram. Next slide. So here it's a very good diagram to show you all the structures which you have studied up till now. This is the inguinal ligament, and just above the middle half of inguinal ligament, this is the inguinal canal. It is present obliquely. You can see it's not straight, and the direction is downward, forwards, and medially. The canal has two ends, the medial end and the lateral end. The medial end has a triangular shaped opening, and that is known as the superficial inguinal ring, which is a gap in the external oblique epinerosis. This triangular shaped gap is obtuse angle triangle, and it has an apex, it has a base, and it has two margins. These two margins are known as the crura, and beyond this apex the two margins are combined together through intercrural fibers. The base of the triangle is resting upon the pubic crest, while on the lateral end this oval opening is known as the deep inguinal ring, and which is an oval opening present in the fascia transversalis, a fascia which is located behind the transversus abdominis muscle. And this deep inguinal ring present in the lateral end lies just lateral to this stem of this inferior epigastric artery. So this is in inguinal canal, this is the superficial inguinal ring, the medial end at the medial end, and this is the deep inguinal ring at the lateral end. So here is another diagram I have used to show you. If you move from forward to backwards, this is external oblique muscle and its epinerosis. A gap in this epinerosis is known as the superficial inguinal ring. Then this is the fascia transversalis lying behind this transversus abdominis muscle. A gap in the fascia transversalis is known as the deep inguinal ring, and if I make a oblique passage between these two rings that will form the inguinal canal. So here you can see I have shown you an intact inguinal canal with 4 walls. Consider it like a box with a roof, anterior wall, posterior wall and the floor, and you can see one opening is present in the medial end and one opening is present in the lateral end. This is the superficial inguinal ring, and that behind one will be the deep inguinal ring. So this diagram is showing you the anterior wall of the inguinal canal. This is the anterior wall, and if we go from front to back, that is from superficial to deep, this anterior wall will be formed by the skin and superficial fascia and external oblique epinerosis. Here you can see an opening present in this external oblique epinerosis. This should be actually triangular in shape. This is known as a superficial inguinal ring, and this anterior wall is reinforced in its lateral 1/3 by this internal oblique muscle. The transversus abdominis muscle lies even more laterally, but it's not contributing in the formation of anterior wall of inguinal canal. So the anterior wall or the anterior boundary is formed by the skin, superficial fascia and the external oblique epinerosis in its whole extent, and reinforced laterally by this internal oblique. So the posterior wall in its whole extent is formed by the fascia transversalis, extraperitoneal connective tissue and the parietal peritoneum. The posterior wall of the inguinal canal is reinforced in its medial 2/3 by the conjoint tendon and at its medial end by the reflected part of inguinal ligament. So here in this diagram you can see the posterior wall of inguinal canal. The roof and the floor and the anterior wall have been removed to show you the posterior wall. This is the fascia transversalis in its whole extent, and as I've mentioned you earlier, that this oval opening present in the fascia transversalis will be the deep inguinal ring. So behind that there will be extraperitoneal connective tissue, and further behind that will be parietal peritoneum. So over here in its medial 2/3 you can see this posterior wall is reinforced by the conjoint tendon, and you know what conjoint tendon is, that the lower fiber of transversus abdominis and internal oblique muscle, they combine together and they form a common tendon that is inserted on the pubic crest and pectineal line, that is known as the conjoint tendon. So basically the fleshy fibers of the internal oblique and transversus abdominis, they arch over the content of this inguinal canal, and while arching they combine and form a tendon known as conjoint tendon that is crossing and inserted on the pubic crest and pectineal line of the pubic bone. So this conjoint tendon is enhancing the posterior wall of the inguinal canal in its medial 2/3. Plus I also told you earlier that from the medial end of the inguinal ligament there is a triangular shaped band extending upward and medially towards the linea alba. That too will enhance the posterior wall of inguinal canal at the medial end. So over here in this diagram you can see this is anterior wall and this is the internal oblique enhancing in its lateral 1/3, and this is the conjoint tendon arching over the cavity of the inguinal canal. The conjoint tendon attaches to the pubic crest, reinforces the posterior canal wall medially, and while arching it also forms the roof of the canal. The transversus abdominis and the internal oblique muscle combine to form the conjoint tendon that arches over the contents of the inguinal canal. So over here I have removed the box shaped roof, and here you can see this fibers of the transversus abdominis internal oblique are arching, combining, forming a conjoined tendon, which is reinforcing the posterior wall of the inguinal canal, plus also forming the roof of the inguinal canal as well. The roof of the inguinal canal is formed by the arched fibers of internal oblique and transversus abdominis muscle. The muscles of the two anterior abdominal wall are the transversus abdominis and the internal oblique will be arching over the inguinal canal and forming the roof of the inguinal canal, and they will go backwards and combine together to form a common tendon that is known as the conjoined tendon that is inserted on the pubic crest and pectineal line, and that will reinforce the posterior wall in its medial 2/3. So here you can see the roof and the anterior wall of the inguinal canal. The posterior wall and floor have been removed. The roof is formed by the conjoined tendon and the meeting of anterior and the posterior walls of the canal. The anterior wall is formed by external oblique muscle shown in this orange, and it is reinforced in its lateral 1/3 by this internal oblique. The wall is weak medially because of the hole in the external oblique, which is known as superficial inguinal ring. The floor of the inguinal canal is formed by the grooved upper surface of the inguinal ligament, and at the medial end by the lacunar ligament. So it is reinforced medially by the lacunar ligament, and it is formed by the grooved upper surface of the inguinal ligament. The floor of the inguinal canal, in this diagram you can see this floor, the posterior wall, roof and anterior wall have been removed, and the floor is formed by incurving of inguinal ligament, which is a part of external oblique muscle, forming a gutter. So medially it forms the lacunar ligament, which is not illustrated over here. So this is the floor formed by the incurving of the inguinal ligament. This floor is enhanced medially by the lacunar ligament, which is a downward extension of the inguinal ligament from its medial end. The inguinal canal is larger in males than in females. So the contents of inguinal canal both in males and females are shown over here, and in females the canal is narrower and it transmits the round ligament of uterus that basically provides the support to the uterus. How it's attached, I've mentioned it in slides later on. Then ilioinguinal nerve and genital branch of genitofemoral nerve and blood and lymphatic vessels passes through the inguinal canal in case of females. Similarly, in males the canal is wider and it transmits the spermatic cord, and what is spermatic cord I've discussed with you later on. Ilioinguinal nerve, genital branch of genitofemoral nerve and blood and lymphatic vessels. Please keep this point to remember that the ilioinguinal nerve is a content of inguinal canal, but it's not entering the canal through the deep inguinal ring. It does exit to the superficial inguinal ring, but it does not enter the canal through the deep inguinal ring. It pierces the internal oblique muscle and then runs between the internal oblique and transversus abdominis to enter the inguinal canal, exits to the superficial inguinal ring, but it does not enter to the deep inguinal ring. And additionally, this runs along the spermatic cord, but it does not become a content of spermatic cord. So this point has to be remembered, that the ilioinguinal nerve, it does not enter the canal through the deep ring. It does exit to the superficial inguinal ring, runs along the spermatic cord within the inguinal canal, but it does not become the content of spermatic cord. So over here you can see in the diagram as well that this is the inguinal canal, and inguinal canal, this one is the inguinal canal, okay, and this rounded structure you are seeing is the spermatic cord. It has an os contents as well that I have discussed with you later on. So this is the inguinal canal. This blackish area is inguinal canal and transmitting this spermatic cord in case of male. In the females there will be a round ligament. And here you can see this is the posterior wall made up of fascia transversalis, and this is the anterior wall made up of external oblique epiderosis. And here you can see the floor made up of inguinal ligament and enhanced by this lacunar ligament over here. So this is a inguinal nerve running inside the inguinal canal along with the spermatic cord, but not inside the spermatic cord. So this is the inguinal canal, and the roof has been removed, and you can see this is the interior wall from external oblique epinerosis, posterior wall with fascia transversalis and opening known as the deep inguinal ring. This is the floor formed by the inguinal ligament. So in the purple you can see this is a spermatic cord in males entering this inguinal canal through the deep inguinal ring, then passing through this cavity of the inguinal canal and exiting through the superficial inguinal ring. So here you can see another picture showing you the inguinal canal with this spermatic cord in case of male, and this is the boundary. You can see this is the interior boundary formed by the external oblique epinerosis. So this is the interior wall of the inguinal canal. This is the inguinal canal with this opening to which the spermatic cord is exiting is known as a superficial inguinal ring, a gap in the external oblique epinerosis. Then this is the anterior wall, which is reinforced in its lateral 1/3 by this internal oblique muscle. And this is the roof of the inguinal canal. You can see this is the fleshy fibers of internal oblique and transversus abdominis combining together and forming a conjoint tendon. And then this is the posterior wall over here. This is the fascia transversalis, and opening inside the fascia transversalis is known as the deep inguinal ring. So you can see the canal and the boundaries, and you can see the spermatic cord along with its 3 coverings in this diagram, with the 2 openings on either side of the inguinal canal as well, the superficial inguinal ring on its lateral end and the deep inguinal ring on its medial end. So inguinal canals, why we have them inside our body? What's the purpose of these canals? Actually, these canals allow the contents of the scrotum to communicate with the intra-abdominal contents. So in case of males, the male gonad, the testes, which are embryologically developed inside the abdomen, which are later on shifted to the scrotum that lies outside the abdomen. So through this inguinal canals, the scrotum can communicate with the intra-abdominal contents. It prevents mobile intra-abdominal contents like the intestines from entering the scrotum and possibly becoming damaged, while at the same time permitting the blood vessels, nerves, lymphatics, vas deferens to supply the scrotal contents. The mechanisms of the inguinal canal, how this inguinal canal usually protects. Of course, the presence of the inguinal canal is the cause of weakness in the lower part of the anterior abdominal wall. This weakness is compensated by the following factors. The several factors are working over the inguinal canal so that this naturally weakened area can be protected from any abnormality. So one of the factors include obliquity of the inguinal canal. As I've mentioned you earlier, that the canal is not straight, it's oblique. So the two inguinal rings, they do not lie opposite to each other. Therefore, when the intra-abdominal pressure rises, like in case of coughing, sneezing and defecation, the anterior and posterior walls of the canal are approximated, thus obliterating the passage. This is known as the flap valve mechanism. So you just have to remember this, that the two rings, the superficial and the deep inguinal ring, they do not lie opposite to each other. They are obliquely placed. So in any case, in any condition, when there is a raised intra-abdominal pressure, like in case of coughing and sneezing or defecation or vomiting, the anterior wall and the posterior wall of the inguinal canal, they come close to each other, and this mechanism is known as the flap valve mechanism. So through this mechanism, the canal is protected so that the viscera behind it, the mobile viscera, usually the intestines, they cannot protrude outside through this naturally weakened area. Similarly, the superficial inguinal ring is guarded from behind by the conjoint tendon and by the reflected part of inguinal ligament. As I explained you earlier, that the superficial inguinal ring is a triangular gap in external oblique epinerosis, is guarded from behind because arching fibers, the transversus abdominis and the internal oblique, will combine together to form the conjoint tendon that will arch over, forming the roof of the inguinal canal and then get inserted in the pubic crest and pectineal line, enhancing the medial end of the posterior wall of the inguinal canal. Plus, the posterior wall was also enhanced by this reflected part of inguinal ligament. So these structures passing behind the superficial inguinal ring, that are the conjoint tendon and the reflected part of inguinal ligament, they are guarding this ring from behind. Just like the superficial inguinal ring being guarded behind by two structures, the deep inguinal ring is guarded from front by the fleshy fibers of internal oblique. So it helps to maintain the integrity of the inguinal canal. So just like we studied the flap valve mechanism, in which the anterior and the posterior walls of the canal were approximated, obliterating its passage, so we have over here the shutter mechanism of internal oblique. This muscle has a triple relation to the inguinal canal. It forms the anterior wall, the roof, and the posterior wall of the canal. So when this muscle contracts, the roof is approximated to the floor like a shutter. So I told you earlier that this internal oblique had three relations with the inguinal canal, forming the anterior wall, forming the roof, and forming the posterior wall in the case of conjoint tendon. So when this muscle contracts, the roof and the floor of the inguinal canal, they get approximated and they close like a shutter. So that is known as the shutter mechanism of the internal oblique. Wall valve mechanism, the contraction of the cremaster muscle helps the spermatic cord to plug the superficial inguinal ring. So what happens when the spermatic cord is exiting through the superficial inguinal ring? The spermatic cord is surrounded by the cremaster muscle, and when this muscle contracts, it pulls the spermatic cord upward, so that this pulling of the spermatic cord will cause the plugging, closure of the superficial inguinal ring, and this is known as the wall valve mechanism. So coming up to the slit valve mechanism, contraction of the external oblique results in approximation of the two crura of the superficial inguinal ring. The integrity of the superficial inguinal ring is greatly increased by the intercrural fibers. So what happens, the external oblique, when the contraction of the external oblique occurs, as we studied earlier, that the gap, a triangular gap in the external oblique epinerosis is known as a superficial inguinal ring, and that opening had two cruras, two margins, and a base. It was an obtuse angle triangle. The two margins of the triangle were known as the crura, and beyond the apex, the two crura were joined together by intercrural fibers. So what happens when the external oblique muscle contracts? The two cruras, the crura of the superficial inguinal ring, they come close to each other, they get approximated, and thus closing this superficial inguinal ring. So this mechanism is known as the slit valve mechanism, that is the closure of the superficial inguinal ring like a slit by the contraction of the external oblique muscle and due to the approximation of the two crura of the superficial inguinal ring. So this is known as slit valve mechanism. So hormones may play a role in maintaining the tone of the inguinal musculature. So hormones can affect the tone of the muscles that forms the boundaries of the inguinal canal, and through that tone, the integrity of the inguinal canal can be enhanced. So whenever there is a rise in intra-abdominal pressure, as in coughing, sneezing, lifting heavy weights, all this mechanism which we studied, like the flap valve mechanism, the shutter mechanism, the ball valve mechanism, the slit valve mechanism, they come to play so that the inguinal canal is obliterated, its openings are closed, and the herniation of the abdominal viscera is prevented. So all these mechanisms, they work just to maintain the integrity of the inguinal canal, obliterating its passage. Of course, it's a natural weakness. So in case of any condition like with conditions with raised intra-abdominal pressures, like in coughing and sneezing, the chance of the abdominal viscera to herniate, to protrude out, is likely to be there. So that's why these factors, they work together so that in such conditions of raised intra-abdominal pressures, these openings, they should remain closed, the canal should be obliterated so that the herniation of the abdominal viscera is prevented. Now coming up with the contents as mentioned previously, we studied that in males the inguinal canal transmits the spermatic cord, and in females it transmits the round ligament of uterus along with the ilioinguinal nerves. So the spermatic cord, a content of inguinal canal in case of males. It is a collection of structures that pass through the inguinal canal to and from the testes, which lies outside the abdomen in the scrotum. It is covered with three concentric layers of fascia derived from the layers of anterior abdominal wall. It begins at the deep inguinal ring lateral to the inferior epigastric artery and exits through the superficial inguinal ring and ends at the testes. So over here in this diagram you can see this is the testes and this is the deep inguinal ring and superficial inguinal ring. Spermatic cord passes through the inguinal ring, inguinal canal, and then exiting to the superficial inguinal ring, and it's going towards the testes. So here is another good diagram to show you all the boundaries the contents of the inguinal canal in case of males, you can also see over here, and the openings are also visible. This is inguinal canal. This is all inguinal canal, and this is the interior wall of inguinal canal made up of external oblique epinerosis, and you can see a triangular opening inside it known as a superficial inguinal ring, and these are the two cruras of the triangle, and they are meeting together through intercrural fibers, and you can see the spermatic cord is exiting through it with its three concentric layers of fascia that I will discuss with you later on. So this is interior wall, further enhanced in its lateral 1/3 by this internal oblique muscle. Then the roof of the inguinal canal is formed by these two fleshy fibers of the internal oblique and the transversus abdominis muscle, and these fleshy fibers, they will combine together to form a conjoint tendon that is inserted on the pubic crest and pectineal line. And then over here posteriorly there is fascia transversalis with an oval opening inside, and that is known as the deep inguinal ring. So you can see the spermatic cord is entering this inguinal canal through the deep inguinal ring and then passing through the cavity of the canal and exiting through this superficial inguinal ring towards the testes. So over here you can also see this ilioinguinal nerve. It actually enters the canal not by passing through this deep inguinal ring, but it enters by piercing this internal oblique muscle, and then it runs between these two muscles, internal oblique and transversus abdominis, by piercing the internal oblique to run through this inguinal canal. So it is a content of inguinal canal, but a content like it does not enter the canal through this deep inguinal ring like the spermatic cord, but it runs between these two muscles after piercing this internal oblique, and then it runs through this inguinal canal and exits to the superficial inguinal ring. So ilioinguinal nerve is a content of the inguinal canal that does not enter through the deep ring, and it runs inside the inguinal canal along with the spermatic cord, but it's also not a content of the spermatic cord. So now coming up with the contents of the spermatic cord. The contents of the spermatic cord consist of ductus deferens, and this ductus deferens is a fibromuscular tube, a part of a male reproductive system that conveys, it's a carrying channel which conveys the sperm which are produced in the testes, stored in the epididymis, to the ejaculatory ducts. Then the spermatic cord consists of arteries. The three arteries are the testicular artery, artery of the ductus deferens, the cremasteric artery. Then the veins. The veins consist of a venous channel known as the pampiniform plexus of veins, and that is made up of 12 veins which is draining into right and left testicular veins. The nerves include the sympathetic nerve fibers on the arteries. These arteries, the testicular artery, artery of the ductus deferens, and cremasteric artery, will be surrounded with the sympathetic nerve fibers. Similarly, this ductus deferens is also surrounded by sympathetic and parasympathetic fibers and genital branch of genitofemoral nerve supplying the cremaster muscle. So these are the contents of the spermatic cord along with this lymphatics, draining the testes and the closely associated structures and some lumbar lymph nodes. So these are the contents of the spermatic cord, and they are being frequently asked in your exams along with the layers of the spermatic cord, the facial coverings, how they are derived, and the contents of the spermatic cord. That's been frequently asked. So here in the diagram you can see a cross section of the spermatic cord, and in this cross section you will see the contents very easily. And here is the vas deferens that conveys the sperms from the testes to the ejaculatory ducts, along with this artery Then this is the testicular artery, and there will be sympathetic nerves around this artery as well as this artery to the vas deferens, and there will be sympathetic and parasympathetic nerve fibers around this vas deferens as well. Then there is the cremasteric artery, and here you can see this genital branch of genitofemoral nerve, and the main focus over here is you can easily see this ilioinguinal nerve over here is not a content of spermatic cord. It's not running inside the spermatic cord. So this is all a cross section of the spermatic cord, and this ilioinguinal nerve is running along with the spermatic cord inside the inguinal canal, but it's not a content of spermatic cord. So coming up with the facial coverings of the spermatic cord. So if we see how the spermatic cord is being covered by three facial coverings from inside to outside. So the innermost layer would be the internal spermatic fascia, and that basically arises from the fascia transversalis. And as I told you earlier, there's a opening inside the fascia transversalis, that is the deep inguinal ring. So this internal spermatic fascia will be attached to the margins of deep inguinal ring. The cremasteric fascia is associated with cremasteric muscle, is the middle facial covering of the spermatic cord, and it arises from the internal oblique muscle. The external spermatic fascia is the most superficial covering of the spermatic cord, and it's rising from the epinerosis of the external oblique muscle and is attached to the margins of superficial inguinal ring. So here it's very good diagram to show you all the facial coverings of the spermatic cord. So over here, this opening, this gap you are seeing is the deep inguinal ring, and this is the fascia transversalis. So there was a gap in the fascia transversalis known as the deep inguinal ring through which the spermatic cord is running. This is the spermatic cord going towards the testes. And over here there is another opening, this one at the green lines junction. Then this is known as the superficial inguinal ring, which is a gap in the epinerosis external oblique muscle. So from inside to outside, if we go, if you see this blue covering and this between the deep ring and the superficial ring, and this is the inguinal canal. So this is the inguinal canal with two openings. This is deep ring and this is the superficial inguinal ring. So to study the facial coverings of the spermatic cord, if you go from inside to outside, you see this blue one, this blue color, this is the spermatic cord, and you see this innermost facial covering, the one colored in blue. You can see if I trace it backwards, it's derived from fascia transversalis. So the fascia transversalis gives internal spermatic fascia, that gives the innermost covering to the spermatic cord, and this internal spermatic fascia is attached along the margins of deep inguinal ring. Then the middle layer facial covering of the spermatic cord, this pink interrupted line you can see over here, is known as the cremasteric fascia. It's derived from the cremaster muscle and the cremaster fascia of the muscle. And this, if I trace backward, you can see it's derived from the internal oblique muscle. So the cremasteric fascia, the middle facial covering, is derived from the internal oblique muscle. And then the most outer layer of this spermatic cord, the one in the green, you can see is derived from external oblique epinerosis, and hence there was a gap in external oblique epinerosis known as superficial inguinal ring. So this external spermatic fascia will be attached along the margins of external oblique epinerosis, and that is the superficial inguinal ring. So the three concentric layers surrounding, encircling the spermatic cord from inside to outside are internal spermatic fascia derived from fascia transversalis, cremasteric fascia derived from the internal oblique muscle, and external spermatic fascia derived from epinerosis of external oblique muscle. In case of females, the content of inguinal canal is the round ligament of uterus. Here you can see the round ligaments. There are two fibromuscular flat bands about 10 to 12 cm longs lying between the two layers of broad ligament. It begins at the lateral angle of the uterus, passes through the deep inguinal ring, traverses the inguinal canal and merges with the areolar tissue of the labia majus. So here you can see this is the uterus and these are the two lateral ends of the uterus. So these are the two fibromuscular flat bands about 10 to 12 cm long. They will enter the inguinal canal through the deep ring and then passes through the inguinal canal, exiting through the superficial inguinal ring to be attached on the labia majora, that is the female external genitalia, hence providing the support to the uterus. Now coming up with the last important topic to be discussed with you is the Hasselbeck's triangle. So basically this Hasselbeck's triangle will more be applicable, this topic will more be applicable in your next applied anatomy class, in which you will study the hernias. So the purpose of describing you this triangle, that is a weak spot in the anterior abdominal wall over here, is so you can easily correlate the information about this triangle with the type of hernia being asked or being studied. So Hasselbeck's triangle is a weak spot of anterior abdominal wall, as it is the site for direct hernias, as it's mentioned over there already. So in your next applied anatomy class, if you study the types of hernias, the inguinal hernias will be of two types, direct and indirect. And the quality of the direct inguinal hernias is that they will, the place from there they protrude is the Hasselbeck's triangle. The site of that hernia will be the Hasselbeck's triangle. So whatever the hernia, whatever the viscera is protruding out through this Hasselbeck's triangle will be labeled as direct hernia. So what is Hasselbeck's triangle? Also known as the Inguinal Triangle, is a weak spot of the anterior abdominal wall, and it has boundaries. The outer border, it has a triangle, it's shape of a triangle, and it has two margins, medial and lateral boundaries, and apex and the base. For that I will jump over to the next slide to describe you the boundaries of Hasselbeck's triangle that are more visible over there. So you can see this is the anterior abdominal wall, and this green colored triangle is a weak spot in the anterior abdominal wall, and that weak spot is known as the inguinal triangle or Hasselbeck's triangle. And this triangle is a potential site for hernia, and the hernia which protrude from this triangle is known as the direct inguinal hernias. So the boundaries of this Hasselbeck's triangle are, you can see these are the two margins. This is the medial margin of the triangle, this is the lateral margin of the triangle, this is the base, and this is the apex. So the medial boundary is formed by the lateral border of the rectus abdominis muscle. So this is rectus abdominis, this is the medial border of rectus abdominis, and this is the lateral border of rectus abdominis. So the lateral border of the rectus abdominis is forming the medial boundary of Hasselbeck's triangle. The lateral margin is formed by the inferior epigastric vessels. The base is formed by the inguinal ligament, and apex where the two margins meet together. So the hernia which protrude through this Hasselbeck's triangle will be labeled as direct inguinal hernia, and that's a natural weak area in the anterior abdominal wall. So here you can see all the structures of the inguinal region shown in the cadaver, and over here you can see this is the deep inguinal ring, and this is the superficial inguinal ring, and you can see the spermatic cord exiting through it and going toward the testes. This is the scrotum enclosing the testes. and you can see this is ilioinguinal nerve exiting through this superficial inguinal ring, and you can see it's not a content of spermatic cord. If it was to be a content, then it could be lying within the inside the spermatic cord. It's coming out separately, so it's a content of inguinal canal but not a content of spermatic cord. And this blue interrupted line is showing you the position of inferior epigastric artery. So this triangle medial to this inferior epigastric artery is known as the Hasselbeck's triangle or Inguinal Triangle. So any hernia that is, or any protrusion of the viscera, abdominal viscera, through this triangle will be labeled as the direct inguinal hernia. So students, this was all about our today's lecture, that we studied inguinal region in detail, the anatomy of the structures located in the inguinal region, including the inguinal ligament and its extension, inguinal canal, its boundaries, its contents, its location, its mechanisms. We studied the contents in detail, the spermatic cord, its facial coverings, and its content in case of females as well. And another thing we studied today was the Hasselbeck's triangle, its boundaries and its clinical importance. So I hope you have understood very well today's topic, and in case of any queries, please you can consult us anytime. Thank you so much and best of luck.